Good morning, everyone, and welcome to this session on pain pathways and the progression of acute to chronic pain by Dr. Mason Habel. So for those who don't know, Mason won the Renton Prize in the most recent sitting. And looking through your notes, Mason, I am not surprised at all because your layout clearly shows that you understand the anatomy of an answer and how it progresses from a pass to a prize-winning answer. So I'm really excited today to listen to all your tips and tricks. I quickly saw the 2 and 5, and I thought that is an amazing thing you picked up. So I'm really excited to listen to what you have to say, especially how all these tips and tricks help you memorize the breadth of concepts related to pain. Now, Mason's chosen charity is on the screen here. So it's the Women's Sport of Australia. And they espouse the values of equity and equality of women in sport and has been a source of meaningful and positive change in our communities. And that's what we're all about here. We're all about equity, equality, and positive change. So without further ado, I'm going to hand it over to you, Mason.
So this next question is outline the physiological mechanisms of the progression from acute to chronic pain and how drugs may alter this progression. He had a really bad pass rate, 24%, but it is a learning outcome, almost word for word. And as much as I've heard the opinion that this is some people consider this quite a mean question, I think it's still fair game to be asked again in the future. When Stan contacted me about this presentation, he gave me a couple of different topics with the options to choose from. And this question was why I wanted to do this topic, because I think it's a confusing area that you can get yourself really bogged down in a ton of information. And I really hope that I can provide a framework that allows you to tease apart the important bits from it. So for me, planning this question, again, it's clearly in two parts. There's the physiological mechanisms and there's how the drugs can alter the progression. Within the physiological mechanisms, for me, I think having a separation in your mind of what is the difference between the observed clinical phenomena, which is your hyperalgesia, your allodynia, these buzzwords like wind up and long-term potentiation, and then the underlying physiological explanations for those processes. The examiners didn't give marks if you just mentioned the clinical stuff and those buzzwords. They needed you to at least make an attempt at explaining how those phenomena occur. And then in terms of how drugs can alter the progression, where possible, I've tried to provide you with some drugs along the pathway for you to think about, but also these general concepts of preemptive and preventative analgesia, which certainly relate to chronic pain transition. The structure for me, throw a definition out there at the start, never hurts you and it potentially gets you a mark. Risk factors, for me, personally, I think discussing the risk factors for chronic pain, it's not specifically asked for in this question, but it's probably one of the only areas about chronic pain that we actually have a good understanding and good amounts of research evidence for what underlies the process. And then I break it down into peripheral sensitization, central sensitization at the dorsal horn, effects at the higher centers and modulatory effects, and then talking a bit about these general analgesic approaches. Can you tell me, mate, what's your definition of chronic pain? And what about neuropathic pain? This is probably the only simple definition I would write for this. Chronic pain lasting longer than 3 months. And I would say to be slightly less upfront that it lasts longer than 3 months and outlasts the conditioning stimulus. So I would say it often is longer than the acute noxious input. The reason I separate that is you can probably break down chronic pain clinically into a couple of different subtypes. I don't think this has any place in this answer, but this is just for your understanding. Patients with osteoarthritis and rheumatoid arthritis, they have chronic pain, but they have a reason for chronic pain. They've got ongoing nociception. They've got mechanical injury occurring. They've got inflammation constantly occurring. So in that case, your definition saying it outlasts the noxious stimulus actually probably doesn't capture this group of patients because they've still got ongoing nociception causing their pain. you do have patients who've got neurological injuries, and so there is a noxious input in the sense that there is a nerve injury and that's constantly feeding and causing pain. And then you've got your more typical chronic pain patient that you see on the pain round, which is they don't have anything going on with them and yet they're in pain, and that's all because their nervous system is buggered. This is the Venn diagram of chronic pain and neuropathic pain, because I think a lot of people just lump these together in their mind as being really synonymous and being much more interrelated than they are. So neuropathic pain is caused by a lesion or disease of the somatosensory nervous system. And it is really commonly associated with chronic pain, and some of the clinical features tend to overlap with many chronic pain features. But not all neuropathic pain is chronic pain. When you see a patient that was in the operating theatre and their arm was in a weird place and they wake up with like an ulnar nerve palsy, that happened yesterday. They don't have chronic pain, but they've probably got a neuropathic lesion occurring there. However, it does have a really high rate of converting from an acute neuropathic injury to a chronic neuropathic pain. And we'll talk a bit about that. Tell me about some patient factors that are risk factors. Patient factors, just think of what your usual pain round chronic pain patient looks like. They're usually a young, depressed, anxious woman who's had chronic pain before and now they've got something else going on. And that's a big generalization, but it's going to help you remember what to write down for some good dot points here. In terms of the surgical factors, so generally bigger, more invasive surgery, an open cholecystectomy versus a lap chole has a much higher rate of chronic pain developing. Intraoperative nerve injury, wound infections, there are various risks. And there are particular groups of surgeries that have a higher than average rate of chronic post-surgical pain. This is typically mastectomy in thoracics around the chest wall. Cesarean sections have a quite high rate. Lots of gynecological surgery, and that just makes me think of all the chronic pelvic pain that these poor surgeons have to look after. And amputations have a high rate of chronic pain as well. In terms of pain factors, this is the severity and the duration of, if somebody's had chronic low back pain for 15 years before they have a back surgery, you might say that they've got chronic post-surgical pain, but really it might just be persisting pre-surgical pain. Patients who have really poorly managed pain in the immediate post-operative period have a much higher rate of developing chronic pain long-term. And as we discussed before with the neuropathic pain has a high risk of conversion to long-term neuropathic pain. In terms of other, detailed patient factors, so lots of catastrophizing, anxiety and depression, or people who are expecting pain and they start just staying in bed all day. These are the yellow flags for back pain that you learnt about as a med student. There's these great lists in like the Grey Handbook for Pain that give you a bunch of options to just drop a few buzz points. Personally, I think it's a bit of a stretch for the examiners to expect risk factors to be discussed, but it is mentioned in their examiner's report. And if you got this question, it's an easy couple, like 1 minute, you bang out patient surgical pain factors, you put 3 dot points for each, and that's definitely a mark before you move on to the next area. And just for your own understanding, I would say that these are observed relationships or associations as opposed to mechanisms. These are over big patient groups, they know that there's a greater rate, but they don't always know why. And you can get chronic pain even if you're a male who doesn't smoke, who's never had pain before, etc. So now we get to peripheral sensitization. So we touched on this a bit before in the first SAQ, that when there's local inflammation, name drop a couple of mediators, prostaglandin, bradykinin, TNF-alpha, that has an effect on the peripheral nerve endings. And that effect is probably that it increases either the number of receptors being presented or increases the sensitivity of those receptors. And the net effect is we say that the transduction threshold has reduced. So it's more irritable, it can be easily excited to send an ascending pain signal. Now, sorry, I have to be really careful saying irritable and excitable because those are very specific cardiac physiology terms that I don't want to confuse anyone with. So, this causes primary hyperalgesia and allodynia, and we'll come to those in a bit when I think I'm going to quiz you on those. Drugs of this area, NSAIDs and steroids. And then separate to the nerve ending, I would talk a bit about the nerve fiber. So this is really when you can think about neuropathic pain. So peripheral nerve injury tends to has the potential to produce spontaneous firing of peripheral nociceptors. And the best explanation I could come across from this, from reading through, is probably that this nerve injury results in an alteration in the sodium channels that get expressed, and some of these sodium channels may almost spontaneously depolarize, triggering an action potential. And so local anesthetics, such as intravenous lignocaine in particular, they can have effects both as anti-inflammatories, and they may have sodium channel blocking effects. And there's some thought that the dysregulation in the sodium channels may produce a channel subtype that's more susceptible to local anesthetics than other sodium channels. Some extra detail on the peripheral sensitization, I would try and get in about the neurogenic flare or the neurogenic edema, this self-propagating cycle of the neuron gets excited, it sends out its own inflammatory mediators, and it re-excites its local tissues and itself. You could mention that in the setting of acute inflammation, there is opioid receptor expression. So you can make an argument that giving opioids in the acute phase may have a role in decreasing the conversion to chronic pain. And certainly we know that effective management of patients' acute pain, of which opioid-based analgesia is often a big part, is effective in preventing chronic pain transition. But that's very different to saying opioids are good for chronic pain. I definitely wouldn't write that in your exam. There's also some thoughts that peripheral nerve injury, as well as the sodium channel alterations, there's probably a change in the calcium channels located on the presynaptic terminal. So at the presynaptic terminal, usually it's calcium influx that triggers the release and degranulation of neurotransmitter vesicles. And these alpha-2 delta, which is what you hear when you hear about gabapentin and pregabalin, that is a subunit within the voltage-gated calcium channel. So in the setting of peripheral nerve injury, a process occurs of which I can find little explanation that tends to result in an increase in the proportion of these calcium channels that contain this subunit. And therefore, pregabalin and gabapentin are likely to have a role in the setting of neuropathic pain, which is their most recognized clinical indication, to decrease the release of neurotransmitters from these sort of hyperexcited, damaged nerves. Can you tell me what is hyperalgesia and what is allodynia? Bonus points if you can tell me what's the difference between primary and secondary hyperalgesia. Noxious stimulus, increased perception of pain. Allodynia, innocuous stimulus, but causes perception of pain. So primary and secondary, you sometimes see these used a little bit wildly and sometimes incorrectly, but there's probably two definitions. So primary hyperalgesia usually relates to the site of injury, and it's generally associated with peripheral sensitization, so inflammation occurring at those nerve endings. Whereas secondary hyperalgesia is, you get stabbed in, your thumb, and then your whole palm starts to hurt. That's probably, that's the surrounding site of injury, and that's probably more related to central sensitization mechanisms. Not something that I think you need to mention in this SAQ, but just so that when you're reading these pain textbooks, you have some idea what these guys are talking about. And in my mind, it's easier if you just, in your brain, just put hyperalgesia and allodynia in the same basket. They're two definitions, but they're the same process. You see these great graphs about, just a left shift of the pain intensity to stimulus curve. And whether it's hyperalgesia or allodynia just depends on the nature of the stimulus that you give. And I'm not sure why I stole this graph from chronicprostatitis.com, but it was what I had in my old primary notes. Then we get to dorsal horn sensitization. So this is where most of the money is for this question, and it's also where the textbooks are the most confusing. So central sensitization here is, it's a similar process, that it's a reduction in the transduction threshold, so how much input is needed to achieve an output. And I break this down and I say central sensitization may cause a number of these clinical or laboratory phenomena. These phenomena include wind-up, where you've got a sustained input of stimuli leads to an increase in output from the second order neuron. You get long-term potentiation, which is a similar kind of description, but occurring over a longer period of time, and it lasts for a much longer period, going into days and weeks. And then you've got those clinical syndromes of secondary hyperalgesia and allodynia, which we've talked about. I then say, the underlying physiology that we think explains these phenomena include things like increased intracellular calcium, and this is where the Nmda receptor is the most well understood cause, so much that they've asked entire SAQs on the topic. There's immediate hyperexcitability, and that probably relates to the wind-up side of things, which the Nmda receptor is it's a ligand-gated calcium channel. There's more channels available for calcium influx, and therefore there can be a greater excitation of the second nerve. That calcium, however, then also activates a range of second messengers that causes short and medium long-term changes. You get altered channel expression, you probably get a local inflammatory response, and you get longer-term changes with gene transcription. The main drugs to mention here are just drop your Nmda antagonists: ketamine, magnesium, nitrous, methadone, xenon. I'll elaborate a bit more on some of that in a moment. So now we come back to those wide dynamic range neurons that we talked about earlier. So wide dynamic range neurons, which we've got on the top right here, they receive input from both the innocuous A beta type fibers as well as the noxious input from C and the A delta fibers. But if suddenly you reduce the transduction threshold, suddenly they might only need this minimal input from the A beta fiber to trigger off this second order neuron to send a painful stimulus up to the brain. And so that can produce A beta leading to ascending pain signal. That's a clearly recognizable cause for why allodynia, the clinical syndrome, may be produced. You also come across about A beta fibers and this concept of sprouting or forming abnormal new connections. So that's what I've kind of done on Microsoft Paint in the bottom right here, which is instead of the A beta fibers often either, just going in and either depressing local C fibers, which is part of why when you rub your arm, it doesn't hurt so much after you get punched. They may form abnormal connections and directly synapse onto nociceptive specific neurons so that their input again sends an ascending pain signal. Another proposed mechanism for allodynia. In terms of the interneurons in the dorsal horn, I would leave it as simply as there tends to be a downregulation of the inhibitory interneurons and an upregulation of the excitatory interneurons. I found almost no reliable discussion on what are the mechanisms underlying those processes in all 10 of the recommended texts. A bit more detail. Wind-up is often like a lab phenomena. Like they would literally get sections of neurons and electrocute them and see how many neurotransmitters they released. And so it's that if you stimulate them for a period of time, they get more and more agitated. Long-term potentiation, that's more of an experimental phenomenon. It tends to last days to weeks, and it's thought to underlie things related to memory and learning, which is why we also think the Nmda receptor is key in memory, not just in pain. There are other causes of increased calcium, not just the Nmda receptors. There's a couple of others here, but the Nmda receptor is certainly the most important one to mention in this question. I think it would be reasonable to say that non-steroidal anti-inflammatories and steroids have a role. One of the consequences of activation of the Nmda receptors is induction of COX-2, which results in prostaglandin and inflammatory media being produced. And therefore, you could very plausibly argue that you're going to decrease inflammation around the nervous system by using these anti-inflammatories. As well as these A beta fibers forming new connections, there's some thought that they may actually have a change in the types of neurotransmitters they produce. They might actually start producing substance P. And then this stuff here, I wouldn't stress too much about it, but that's about the only explanation I found for what might underlie the changes in interneurons within the spinal cord. And that's like a dot point or a sentence across 5 or 10 textbooks. So this is my cognitive framework for how I was able to come to terms with this absolute shit show of chronic pain physiology. You say, in my mind, central sensitization is the big umbrella banner. Underneath it, you've got wind up, which is the shortest manifestation. Lots of input leads to increasing output. Long-term potentiation equals basically the same thing, but it just occurs of longer input and then the effects stay for a longer period of time. Secondary hyperalgesia and allodynia, that is what you clinically observe in your patients because of wind up and long-term potentiation. Interneuron plasticity, these inhibitory ones going up and inhibitory ones going down and the excitatory ones going up. It's a buzzword to mention. Don't stress yourself about it too much. And I personally think that discussions about the effects of the sympathetic nervous system are really complex. That's about like complex regional pain syndrome, and it's a big rabbit hole that I strongly discourage you from looking at. I think for me, separating very clearly what are these clinical or lab phenomena from the physiological explanation allows you to not get so caught up, because many of the textbooks do not label it anywhere nearly as clearly as this. Some of the textbooks are really clearly, they will say Nmda receptors cause wind up, but then others will just say, here's a bunch of phenomena, here's a bunch of mediators and mechanisms we think might be relevant, but we're not really sure what relates to what. But the examiners wanted you to have a crack at relating the two. And personally, I think that despite the exam report saying they wanted you to discuss phantom pain and memory, I think that's very cruel for this question. All right, now I'm going to have a bit of a rant about the NMDA short answer questions. So can you describe for me the priming and activation of the NMDA receptor? It is neurokinin 1, or is it? Who knows? Because the examiners are really annoying. So they asked a question about the NMDA receptor in 2003, and the examiner's report says, priming, it's associated with, but not part of AMPA receptor and neurokinin 1 receptor, stimulation of which causes partial depolarization and allows the magnesium plug to leave the central pore. And then they asked the same question in 2020, and the examiner said, substance P and the neurokinin 1 receptor are not involved in NMDA activation. Like, this was probably the most frustrating example of examiner conflicts that I came across during my primary exam. You just have to accept that examiners are not perfect. I've also referenced the Grey Handbook published by the College of Anaesthetics, which says that both of these are related. So I would write them both down, and then I would just be frustrated afterwards with the examiner. People make mistakes, it's not perfect. But rant over. Then we get to the higher center effects. And this is, you'll note that I've got much less detail here because even less is understood about this part of the transition from acute to chronic pain. So there seems to be an association that certain psychiatric and social risk factors, which you've discussed earlier in your answer, tend to result in an increase in descending excitatory modulation and a decrease in descending inhibitory modulation. And that's probably often relating to the PAG. Drugs that may have some action here, ketamine may have an action. It's thought prolonged infusions of ketamine, people getting on them for like 5 to 7 days, are being used as antidepressants and perhaps as like long-term resetting therapy in certain chronic pain indications. And antidepressants may have a role not just for their serotonergic or noradrenergic effects at the dorsal horn, but as terms of changing your higher center physiology. But again, the specific underlyings of this are not well established. Just a final point on some terminology that you might come across. You've probably come across the phrase diffuse noxious inhibitory control. And sometimes people say, this is not working properly in patients that have chronic pain. I never understood what it was until about a week ago, but basically it's like when you stub your toe, your body actually tells the rest of your body that it doesn't hurt, so that it draws all of your attention to your sore toe, so you stop doing what the problem was. And so, it's plausible that this process being sort of poorly developed has the potential to result in, an increase in pain sensation. But I would never mention this in a short answer question. It's just in case it comes up in a Viva. And if this comes up in Viva, you're doing very well. Can you give me a crack at a definition of preemptive analgesia? Cool. So your definition for preventative is perfect. Your definition for preemptive, I would just adjust ever so slightly to say that it is more effective when given prior to the noxious input compared to given afterwards. You can, as opposed to any drug that you give before the noxious input is therefore preemptive. And that's kind of, another Venn diagram of how they relate to one another. The preventative in green is probably the more important to discuss, but I still think there's a place for both of these to be discussed in your answer. So preemptive analgesia, as you said, the effect is greater if you give it before as opposed to after the noxious input. You know, regional analgesia and thoracic epidurals in particular are probably best understood for this, which is why we used to give thoracic epidurals for major abdominal surgery to everyone until intrathecal morphine ran them out of business. And pre-op Panadol is the easy one that I remember. That, you know, Panadol works better if you give them a gram orally before they have surgery, as opposed to giving it to them intravenously when they're under analgesia, under anesthetic. Preventative analgesia, your definition was perfect. And the key drugs implicated here are your Nmda antagonists like ketamine, local anesthetic, either given in the tissues, in a nerve block, intravenously, or in the spine, all have preventative roles. And pregabalin is thought to maybe have some benefit for neuropathic pain, but it's less well established than other things. And so that's, you know, ketamine, lignocaine, local, maybe pregabalin. Regional kind of falls into a mixture of both. And just some other points that, you know, if you got some extra time at the end, you could drop out that, you know, effective management of acute pain tends to decrease the incidence of chronic pain by whatever analgesic mechanism you choose. And potentially, like, I certainly think that you get some bonus points if you mentioned that acute high-dose opioid use can actually be deleterious. The most clear example being remifentanil-induced hyperalgesia, which I think is related to, like, its carboxylic acid metabolite or something, which you might come across in some of your pharmacology study. And important drugs which are not preemptive, aka if you give them pre-op compared to post-op or intra-op, it's no different. So non-steroidals, you know, giving someone some Nurofen before their surgery is no better than giving it to them afterwards. Ketamine, in fact, if you start somebody on a ketamine infusion before you put them off to sleep and then they have their laparotomy, at current evidence does not suggest any difference compared to if you start it intraoperatively or post-operatively. And opioids as well. You know, often before the surgeon makes their incision, we'll give them a big slug of some long-acting opioid to almost make sure they're analgesed at the time of the incision. But there's no strong evidence to say that that's any better than waiting until the surgeon cuts them and then giving them the opioid. But we still do it anyway, because the general concept of the management of acute pain and decreasing the amount of input is accepted, but I don't think there's good sort of clinical research that has established this. Generally, the terms preemptive and preventative, they get mislabeled a lot in the textbooks, and often so I would use the definitions that I put here, which I've got from the Grey Handbook, but just be aware that some textbooks use them quite liberally and inaccurately, and most of the preemptive stuff doesn't get studied anymore because people aren't worried about giving it pre or post incision. They're just worried about if it prevents the conversion to chronic pain. And that's it. Any questions from anyone?
Mason, I just had a quick question about allodynia. So I'd always learned that allodynia occurred at the dorsal horn, not peripherally, because of those like wide dynamic range neurons and sprouting. So is there a mechanism where it happens peripherally as well?
So in my mind, if I was ever asked, you know, what are some different mechanisms of allodynia, the explanations that I've come across are that peripherally, when you've got inflammation in the tissues, that can reduce and that's in the first presentation I mentioned silent nociceptors, which they're very sparsely mentioned, but it's basically under normal physiology, they don't do anything, but when they're sensitized, they can then transmit a noxious input. So in the setting of peripheral inflammation, you've got these silent nociceptors, which now become active, and a smaller amount of input can produce a painful response, as opposed to the more central causes being either Nmda related stuff with wind up and long-term potentiation, or the sprouting with the A beta fibers onto so it's either like sensitization of the wide dynamic range or sprouting onto the nociceptive specific neurons. I will happily agree with you that it is very rarely labeled so clearly in textbooks. And some pain physicians would probably say that I'm making it far too simple for what is understood of the process.
Okay, so is it then that with the silent nociceptors, because they've got a reduced threshold, even a non-nociceptive stimulus will activate them?
That would be my best guess of the process.
Right.
But you take it with as much salt as is reasonable, I think.
Yeah, cool. Thank you.
Good question.
Mason, thanks so much for that. Do you mind, just sort of similar to the last 5-minute summary that Stan asked you to do that same thing for this question as well? Something I really struggle with, particularly in explaining dorsal, like central sensitization, is just the emphasis points about it, because I feel like there's just so many different little points within that I'm like, I just get lost in the detail, and I don't know what should definitely be there and what I should just say as, okay, if I get time, that'd be great, but if not, that's fine.
Yeah, so I think in the back of your mind as well, this is not the question about the Nmda receptor. So you need to put some information in about that, but not just give your entire answer to that concept. So I mean, I'm cheating and I'm putting my structure up here to talk along with it. So I'd start with the definition of chronic pain. That takes 20 seconds. I would bang out a bunch of risk factors, patient, surgical, and pain factors. That's a minute and you're on to the meat of your answer. I'd start peripherally. I'd talk about either peripheral inflammation, the self-induced peripheral inflammation with that neurogenic flare, and I'd talk about nerve injury peripherally and the effects that can have. Getting into the dorsal horn, which is certainly the core of your answer. So I would word up at the start, central sensitization results in it involves a reduction in the transduction threshold of second-order neurons. This can result in various phenomena, including wind-up, give a definition, long-term potentiation, give a definition, hyperalgesia, give a definition, allodynia, give a definition. Then I would say the physiological mechanisms thought to explain these phenomena include, and I would say increased calcium influx, bracket Nmda receptor priming and activation is a key implicated receptor. This calcium causes immediate hyperexcitability, as well as causing second messenger and long-term changes, including a local inflammatory response and as well as gene transcription. I think the stuff about the sprouting of A beta fibers, that's probably bonus really. And if you ran out of time for that, it's not going to fail you this question, but it is mentioned in a number of textbooks and it would be good to get across. In terms of the higher center and the modulatory effects, in fact, I feel like I skipped a slide on that. Basically just, the psychiatric stuff, at some point, patients with these risk factors tend to have an underactive PAG RVM axis and an underactive locus coeruleus axis, and they have overactive descending excitatory pathways, but the mechanisms underlying this are not well understood at all. Good question, Kerry.
Great, awesome, thank you.
No worries. Any others?
Sorry, Mason. Yeah, I've got a question as well. Thanks very much for your time anyway. But I was wanting to ask about mainly about structure of both of the two questions that you've covered. Do you think it's better to try and integrate the drug elements into each of your headings, or do you think it's better to describe the phenomena and then finish with how the drugs link in?
So
kind of applies to both.
I think for the first question, which is about the pathways and drugs along the pathway, I think the safest thing to do is mention the drugs at each step along your answer, because you're much less likely to burn all your time giving all the knowledge that's in your brain about the pathway and then go, shit, I haven't put enough effort into the drugs, and shoot yourself in the foot at the end. I think it's quite, I'll admit, even with time to think about it, the structure for the acute to chronic pain it's not a simple one. The risk factors doesn't nicely fit in. It's kind of just something you've got to drop in there, much like a definition. It doesn't always really feel like it's the logical start for me. Sometimes it just feels like you're placating the examiner, to be perfectly honest. I think that where possible, I would try to mention some drugs along the way. So, peripherally, you're talking about anti-inflammatories. Centrally, you're talking about ketamine and maybe gabapentinoids. And then in terms of where preemptive and preventative analgesia, I don't think they fit nicely to say that they fall under peripheral or they fall under central. I think that they warrant an entire discussion on their own. Whether you mention those at the beginning because you think then you can mention the drugs as you go along, I think that would be completely appropriate as well. And actually, if you just move 0.6 here up to 0.3, I think that could work quite well as well.
Awesome. Thank you very much.
No worries.
Thank you so much, Mason. And really appreciate the generosity and the time you've taken to come today and present the idea of that pain and the progression from acute to chronic, despite all its complexity, can actually be summarized in 2 hours. And I think this is what this exam's all about. It's about distilling all that information and being able to communicate it to someone else in a very succinct fashion. And I think that the more complex an idea is, I think we seek for that simplicity, which hopefully everyone has found useful today. So thank you so much, Mason.
Yes, thanks very much for having me along, Stan. I know I sent out basically the same notes beforehand. I'll also send out my text recommendations as well. And if anyone didn't get them, you can get in touch with me or with Stan, and we'll be able to forward them through to you.
I'll just go on a rant.
Go for it. That's what this exam's about. I felt like, do you feel like, Stan, now that you don't have I'm not sure if you still keep in touch with your primary study group, but study group was such an important venting part of anaesthetic training. And as Stan knows, my study group was at times as big as 6 people, but at others as small as 4. And, Catherine, who's your next presenter, and I were in the same study group. And obviously we both did quite well. So I think it's a good testament to a good study group can really push everyone further forward.
And I think that's a testament, because I think that, your study group actually made me realize that it's not just always about the ideal number, because I think traditionally we've always thought that 4 is sort of the ideal number, but you've actually showed that you can actually function really well as long as you've got a good structure in place in terms of the goals that you want to achieve,